What do we know about the proper use and maintenance of IV lines and best practices to prevent patient adverse events related to IV lines? How can we stay current with new technologies? This education session addresses these issues and more. Today we look at vascular access devices. You will encounter pre-tests throughout the education session for your contemplation. The pre-test questions will not need to be answered until the conclusion of the entire presentation. At that time, you will complete the post-test. So let's begin. Remember, saving lines saves lives.
While vascular access devices are patient lifelines, they also present serious risks to every individual with one. Let's look at some statistics. 25% of all central line usage results in occlusion. $100,000 was spent on catheter clearance in a 5.5-month period at Fletcher Healthcare. Catheter-related bloodstream infections are the most costly and life-threatening of all healthcare infections. Between 14,000 to 28,000 patients die annually due to central line infections. CRBSI costs up to $29,000 per case and prolong hospitalization by a mean of 7 days. Since October 1, 2008, Center for Medicaid Medicare Services will not reimburse for hospital-acquired CRBSI.
Asepsis is the first step in protecting patients from complications related to vascular access. For lines in place 10 days or more, the majority of bloodstream infections related to central lines are caused by improper care and accessing and are intraluminal, from inside the line. You are the gatekeeper between bacteria and a potentially life-threatening infection for each of your patients every time you use a vascular access device.
Principles of asepsis are the foundation for providing safe care during patient interventions, particularly if they are invasive. Medical asepsis is used during non-sterile interventions. Scrubbing the needleless connector for 15 seconds is an example of a medical asepsis practice. Surgical aseptic technique is used for procedures that significantly interrupt the patient's first line of defense, the skin. The placement and subsequent management of central vascular access devices is one of those interruptions. For example, maximum barrier precautions must be used for placement of all central lines. Biofilm. It's in rivers and streams, known there as didymo or rock snot, and it's all over any medical device that is inside a patient's body. Nearly 100% of bacteria form communities that attach to surfaces like catheters, as opposed to being free-flowing in the bloodstream. While the study of biofilm is relatively new, it clearly has major significance in relation to its impact upon patient safety. Here are a few examples of where biofilm will reside. Biofilm is pernicious and largely resistant to all known forms of antimicrobials. Almost all microorganisms are embedded in matrices of these complex biofilm communities or colonies. Biofilm begins forming on vascular access devices almost immediately upon contact with the patient's bloodstream. The biofilm allows the microorganisms to adhere to any surface, living or non-living. Microbial biofilms are responsible for 65% of infections treated in the developed world. The adaptive and genetic changes of the microorganisms within the biofilm make them resistant to all known antimicrobial agents. Vascular catheter-related bloodstream infections are the most serious and costly healthcare-associated infections and the most life-threatening. 87% of primary bloodstream infections are associated with an intravascular device. Biofilm clumps can be released into the bloodstream. Biofilm is a slimy glue-like matrix created by bacteria that cannot be eliminated and is resistant to antibiotics.